Hi everybody, welcome to this video. I'm so excited to have you here today. So right now I'm studying for my board exam and I am currently going through pediatrics, so I thought I'd throw up a high yield pediatric review of neurology. And so this is pretty much almost everything you need to know for that's high yield for neurology for step 2 CK. So I'll go through all these bullet points. It's really unorganized and random and like hodgepodgey. So it's not the best for like learning for the first time, but it could be a good introduction if you need like a brief summary, or if you've already studied the subject, then it can be a good overview right before your exam. If you're taking a pediatrics shelf, or if you're either taking step 2 CK or if you're taking step 3. So first one is neurofibromatosis. And I know that neurofibromatosis can get kind of like confusing because there's two types for it. So we'll talk about NF1 first. And this is associated with the neurofibromatosis tumor suppressor gene. For NF1, sorry, so it's the NF1 tumor suppressor gene, which makes sense because we're talking about NF1. And then that gene codes the protein called neurofibromin. Sorry, typo here, neurofibromin. And the location of the mutation is going to be on chromosome 79. Or 79, sorry, I'm out of it. It's early in the morning right now. Chromosome 17. So in terms of main clinical features, what you'll see is cafe au lait spots. I think that I had like some autocorrect going on here because everything is spelled incorrectly for this. But anyway, cafe au lait spots, multiple neurofibromas, which you can see on the skin. So cutaneous neurofibromas, Lish nodules, which of course you can see on the eyes. It's like that yellowish looking like pigmentation of the iris. And then you're also going to see axillary freckling, which isn't going to be present in NF2, and optic gliomas, high yield optic gliomas, which are not going to be really present in NF2. So those are all things characteristic for neurofibromatosis type 1. Neurofibromatosis type 2, it's associated with the NF2 tumor suppressor gene, which codes the protein Merlin. So you have to remember Merlin for NF type 2. And then for this one, it's associated with chromosome 22. And then the main clinical features are going to be bilateral acoustic neuromas, as well as juvenile cataracts. And then mode of inheritance for both types is going to be autosomal dominant. Next point that I want to bring up is the gold standard diagnosis for Duchenne muscular dystrophy. And that's going to be genetic studies, which is going to reveal a deletion of the dystrophin gene on the chromosome XP21. Oops, sorry. I don't know why it's... Okay. So gold standard for a diagnosis of Duchenne muscular dystrophy is going to be genetic studies, which reveals the deletion of the dystrophin gene. So the dystrophin gene is getting deleted from chromosome XP21. And then, so muscle biopsy, I know can also be kind of considered as or thought of as a gold standard, but it's not the gold standard. So just remember that genetic studies are the gold standard and not muscle biopsy. Next one is Friedreich ataxia. So this is pretty high yield, and I'm sure you're already aware of this, but we'll go through it quickly here. Friedreich ataxia, the most common cause of death is going to be hypertrophic cardiomyopathy. It's autosomal recessive and inheritance pattern. And then it also is going to present with staggering gait, frequent falls, nystagmus, dysarthria, pes cavus, which is high arches, hammer toes, kyphoscoliosis, and diabetes mellitus. So remember that picture on UWorld where they show a huge heart for Friedreich's ataxia. That's going to be important to remember. And then also you want to note here that Friedreich's ataxia is going to be associated with the frataxin gene. So frataxin gene. Next one that we have is going to be homocystinuria. So homocystinuria is going to be inherited through an autosomal recessive pattern. And then there's going to be intellectual disability, thrombosis, high yield thrombosis, remember that. So We'll talk about that a little bit later on, why that's important, but thrombosis is going to be important. Think about hypercoagulable states when you think about homocystinuria. And then also downward lens dislocation, in contrast to Marfan syndrome, which has upward lens dislocation. So you see downward. So homocystinuria, remember downward lens dislocation. You'll also see megaloblastic anemia, varicomplexion, and the treatment is going to be vitamin B6, B9, B12, as well as antiplatelets and anticoagulation, because remember they are hypercoagulable. This is in contrast with Marfan syndrome because they both can have marfanoid habitus. So Marfan syndrome is going to be autosomal dominant. Patients will present with normal intellect as opposed to homocystinuria where they present with intellectual disability. And then there's also aortic root dilation. And again, remember that upward lens dislocation. Fragile X is the most common inherited intellectual disability in kids. The NF1 tumor suppressor gene normally codes for neurofibromin, and that is a negative regulator of RAS. I think that means the reticular activating system, but I'm not 100%. Perineal syndrome is characterized by bilateral eyelid retraction and paralysis of conjugate vertical gaze due to a lesion in the superior colliculi. So remember, the superior colliculi gets damaged somehow, whether it's a stroke, hydrocephalus, or pinealoma, then that's going to result in Perineal syndrome. So remember that conjugate vertical gaze, so they have that thing where they can't really move their eye properly, so they're going to have that conjugate vertical gaze, and then bilateral eyelid retraction. Ooh, this next point is very important. So Sturge-Weber syndrome. It can be remembered with the mnemonic Sturge. So first thing that you want to remember is that it's a sporadic mutation, not a genetic mutation that causes Sturge-Weber syndrome. Next thing that you want to remember is that it's a port wine stain that's present on the face. Also, you want to remember these tram-check calcifications that are seen on X-ray with the opposing gyri. Next thing you want to note is that it's unilateral. It's also going to cause mental retardation or intellectual disability. These patients can also present with acute closure angle glaucoma, and it's going to be an activating mutation of the GNAC gene, and then they can also present with epilepsy. So remember, sporadic mutation, not inherited mutation, port wine stain, tram-track calcifications, unilateral, intellectual disability, glaucoma, or GNAC gene is the gene that's affected, and then they can also present with epilepsy. The next bullet point that I want to talk about is subependymal giant cell astrocytomas that's associated with tuberous sclerosis. So we'll go over that in a little bit more detail later on. Sorry, I'm not able to scroll down for some reason. Oh, there we go. Okay, so next point that I want to bring up is homocystinuria. So again, remember that we talked about how homocystinuria is going to homocystinuria causes increased risk for thrombosis and atherosclerosis, and that's going to be associated with stroke and MI. So that's why you put them on anticoagulation and antiplatelets to prevent stroke and MI from occurring. Von Hippel-Lindau disease, remember, is autosomal dominant. And then, so we can remember the mnemonic. There's two different mnemonics for tuberous sclerosis, and one of them is hamartomas. So H is going to be CNS, or hamartomas in the CNS and skin. Hamartomas in the CNS and skin. The next one is angiofibromas, or adenoma sebaceum. On the face, you'll typically see that. Next one is mitral regurgitation, ash leaf spots, so hypopigmented macules, cardiac rhabdomyoma, tuberous sclerosis, autosomal dominant. M stands for mental retardation or intellectual disability. A stands for renal angiolipoma, angiomyolipoma. And the S is going to stand for seizures or Chagrin patches. And then in this table here, we have evaluation of head trauma in children ages 2 to 18. I know it's very tiny, so I'll read it out loud. any of the following are going to warrant a head CT scan without contrast. So any focal neurological findings can cause it. Skull fracture, especially basilar skull fracture if they're having seizures, that can be a reason. If they have persistent altered mental status, that can also be a reason. If they have prolonged loss of consciousness, then that can also be a reason for getting a head CT without contrast. There we go. Okay, so next one here is going to be GCS 15 with any of the following: vomiting, headache, questionable, Okay, so vomiting, headache, questionable or brief loss of consciousness, injury caused by high-risk mechanism of injury or severe mechanism of injury. In this case, it's clinician preference whether you want to get a head CT without contrast or observation for 4 to 6 hours. If they've had minor head trauma with a GCS of 15 with non-severe mechanism, no vomiting, headache, loss of consciousness, or signs of fracture, then you don't have to do a head CT. Next, we have absence seizures. So absence seizures are easily provoked by hyperventilation, high yield. So absence seizures are easily provoked by hyperventilation. They have 3 Hz spike wave discharges during episodes. Comorbidities include ADHD and anxiety. They also have preserved muscle tone, short duration, less than 20 seconds, and then simple automatisms are present, as opposed to non-epileptic episodes where they just have like staring spells. Those, they don't have automatisms present, like lip smacking or like blinking and things like that. Tuberous sclerosis. So this is a neurocutaneous disorder associated with ungual fibromas, which are flesh-colored lumps emerging from the nail folds. This is a good picture to look up on Google, so I recommend doing that. Sorry I didn't include it in this presentation. Tay-Sachs disease may be differentiated from Niemann-Pick disease by presence of hyperreflexia and the absence of hepatosplenomegaly. So remember, Tay-Sachs, hyperreflexia, and absence of HSM. Next one is going to be metachromic leukodystrophy. This is going to be due to a deficiency in the enzyme aryl sulfatase A, and it's characterized by central and peripheral demyelination with subsequent ataxia and dementia. So if you see dementia in a kid, think immediately of metachromic leukodystrophy. 4 major childhood tumors: pilocytic astrocytoma, medulloblastoma, remember this is the most highly malignant one out of all 4, ependymoma, other ones are relatively benign, and then craniopharyngioma. Ependymoma is a pediatric tumor that may present as obstructive hydrocephalus and will appear as a mass with scattered calcifications, most commonly within the 4th ventricle. Next point that I want to bring up is going to be tuberous sclerosis. Again, there's another mnemonic for this, so we'll just go through this briefly here. So what are the major features of tuberous sclerosis? Ash leaf spots, which we talked about, angiofibromas, which we also talked about, Sjogren patches, seizures, rhabdomyomas, retardation, myelolipomas, subependymal astrocyte proliferation, and hamartomas. So it's a lot to remember. Definitely go through that a couple of times. Make sure you have it down pat. Ash leaf spots, angiofibromas, Sjogren patches, seizures, rhabdomyomas, retardation, angiomyolipomas, subependymal astrocyte proliferation, and hamartomas. Homocystinuria is a metabolic disorder that may present with marfanoid status, and it's typically caused by cystathionine synthase deficiency. So we talked about homocystinuria again. Remember, they present with mental retardation, And then they also present with like fair skin, marfanoid habitus, and then they have like that downward lens dislocation. So marfanoid habitus, let's talk about this briefly here. So they have ectopia lentis, increased arm to height ratio, breastbone dips inward or outward or protrudes outward, joint hypermobility, arachnodactyly, taller, slender build, decreased upper to lower body segment ratio. They have flat feet. They have kyphosis and or scoliosis. And that's it for marfanoid habitus. Next thing I want to talk about are clinical features of pineal masses. So Perinaud syndrome is one characteristic. So this is also known as dorsal midbrain syndrome. So they're going to be limited to upward gaze. There's upper eyelid retraction, which we talked about, upper eyelid retraction, Collier sign. And then the pupils are non-reactive to light, but they're reactive to accommodation. So non-reactive to light, but reactive to accommodation. Then also you can see obstructive hydrocephalus with pineal gland masses. So they'll have papilledema, headache and vomiting, and ataxia. So look for that in the question stem as well. Friedreich's ataxia is a trinucleotide repeat disorder that causes degeneration of the cerebellum and multiple spinal cord tracts. Pilocytic astrocytomas are most commonly found in the posterior fossa, such as the cerebellum and maybe supratentorial, which intracranial hemorrhage most commonly presents in premature infants within the first 72 hours of life. That would be intraventricular hemorrhage. Focal seizures originate from a single cerebral hemorrhage. Sturge-Weber syndrome is also a developmental anomaly of neural crest derivatives due to somatic mosaicism. So remember that somatic mosaicism because it's a somatic mutation, not an inherited mutation. Sturge-Weber is also known as encephalotrigeminal angiomatosis. Guillain-Barré syndrome results in inflammation and demyelination of the peripheral nerves and motor fibers. Which of the following is the most likely or common sequelae of bacterial meningitis in children? That would be hearing loss. What is the most likely diagnosis in a patient who presents with unilateral hemiparesis that resolves within 4 hours after following a seizure? That would be Todd paralysis. Infant botulism is caused by Clostridium botulinum spores, which are found in environmental dust and honey. What is the treatment of choice for infant botulism? That would be human-derived botulism immunoglobulin. So remember, that's in contrast to adults, where if they get foodborne botulism, then you give them the horse-derived one. In babies, you want to give them the human-derived botulism immunoglobulin. Next question. What is the most likely diagnosis in a child that presents with multiple staring episodes accompanied by head tilting and mouth chewing, followed by a transient period of confusion? Focal seizure with impairment of consciousness. What is the most likely diagnosis in a child that presents with hemiparesis and aphasia hours after falling down with an object in their mouth? That would be internal carotid artery dissection or thrombus formation. So think of like a person putting a toothbrush into their mouth and then having trauma from that. That would be internal carotid dissection. Which of the following is the diagnosis in a non-dysmorphic infant that presents with bilateral extremity hypertonia and hyperreflexia with equinovirus deformities of both feet? That would be cerebral palsy, the spastic diplegia subtype. What is the likely diagnosis in an infant that becomes cyanotic and experiences transient loss of consciousness after crying from an upsetting event? That would be a cyanotic breath holding spell. And so let's go back to cerebral palsy. I have a chart here. So risk factors for cerebral palsy are going to be prematurity. That's the most important one to note. The rest you can kind of know if you want to know them, but definitely know prematurity. Intrauterine growth restriction, intrauterine infection, antepartum hemorrhage, placental pathology, multiple gestation, maternal alcohol consumption, maternal tobacco use. Management is going to be physical, occupational, and speech therapies, baclofen and botulinum toxin for spasticity. Comorbidities include epilepsy, strabismus, scoliosis, and intellectual disability. And then next I go off on a side and talk about brain abscess. So let me just go through this quickly. Microbiology of brain abscess, viridin streptococci, Staphylococcus aureus, or gram-negative organisms. Pathogenesis is going to be direct from adjacent infection. So look for a patient with like sinusitis, otitis, and dental infection with like all of a sudden having a fever and a seizure. It can also be hematogenous, hematogenous. I don't know why I'm having problems pronouncing this right now. Anyway, from distant infection. So that's endocarditis or osteomyelitis. Manifestations are going to be headache, fever, focal neurological deficits, seizure, and then you want to look at brain imaging, which will show one or greater than one ring-enhancing lesion with central necrosis, prolonged antibiotic therapy, and aspiration or surgical drainage or treatment. Okay. So which lysosomal storage disease is caused by a deficiency in hexosaminidase A? That's going to be Tay-Sachs. And remember, syringomyelinase deficiency is associated with Niemann-Pick. The incidence of neonatal intraventricular hemorrhage may be reduced by preventing preterm labor and administering antenatal maternal corticosteroids. Which drug should be given to abort a febrile seizure? I hope that you're thinking or concerned about lorazepam. And then what imaging is indicated? If it's a complex seizure, then you want to do an LP, EEG, and CT and MRI. So for classical galactosemia, this is going to be a galactose-1 phosphate uridyl deficiency. It's going to present with bilateral cataracts in infants, failure to thrive, jaundice, hypoglycemia, and hepatosplenomegaly. Down syndrome patient with back pain, ataxia, incontinence, and quadriplegia. I want you to think about atlantoaxial instability, which is excessive mobility between C1 and C2 causing spinal cord compression. Williams syndrome, think of it, it's a deletion on chromosome 7. They're going to have alpha and facies, hypersociability, increased empathy, and hypercalcemia. It's also associated with supravalvular aortic stenosis, so a murmur heard at the first right intercostal space. Opsoclonus myoclonus ataxia is a paraneoplastic syndrome associated with neuroblastoma, involving rapid and multiple directional eye movement, rhythmic jerks of the limbs, and ataxia. Lennox-Gastaut syndrome, the age is going to be 3 to 5 years. Developmental delay or loss of milestones after onset of seizures. Anticonvulsant therapy or ketogenic diet. Infantile spasms, as also known as West syndrome, symptoms occur less than 1 year with symmetrical limb jerking, not generalized, negative fever. Diagnosis with interictal EEG with hips arrhythmia. And then treatment for this is ACTH. And then lastly, we have a child presenting with intellectual disability, happy demeanor, laughing, fascination with water. Disease and cause is going to be Angelman syndrome with a maternal chromosome 15 deletion. So remember that whole genetic imprinting, all of that good stuff, like Prader-Willi, then that's all associated with this here. It's not as high yield for step 2 than it was for step 1. And then neuroblastoma, so pathogenesis is going to be neural crest origin, involves adrenal medulla sympathetic chain. Median age is less than 2. It presents as an abdominal mass. There's periorbital ecchymosis or orbital metastasis, spinal cord compression from epidural invasion, so it's known as a dumbbell tumor, and opsoclonus myoclonus syndrome, which we just talked about. Diagnostic findings are going to be elevated catecholamine metabolites, and then small round blue cells on histology, and NMYC gene amplification. And that's all for pediatric neurology. I hope that helps. If you have any questions, feel free to leave them below. Thank you so much for watching. Until then, take care. Bye.